Dear colleagues, ladies and gentlemen, cystic adnexal masses encompass a broad spectrum of lesions, and these range from physiological cysts to all types of tumors, and they include also inflammatory masses. However, we should keep in mind that the vast majority of these lesions will be benign and of ovarian origin, and up to 18% of the cases will be found as incidentalomas. So the learning objectives in these sessions is to learn about specific imaging algorithm, to understand imaging features that differentiate ovarian from non-ovarian cystic tumors, and to become familiar with pitfalls in imaging of these tumors. For long times, sonography has been established as the first-line imaging modality to assess the ovaries, and it guides also further treatment or imaging. For instance, if we have a mass like this is clear benign, here the patient should go for either follow-up by sonography or surgery. However, if a mass is malignant, like here, as we've already heard, their staging CT should be the next diagnostic step. And if we have lesions that are indeterminate, and that will be true for approximately 20% of the lesions, this is where patients will benefit from further imaging with MRI or CT. And before I go into detail, I'm interested in your clinical experience. This is a lady, she's 64 years of age. She presents with a mass that is cystic, that has thick septations, and there might be a solid lesion at the border of these lesions. So what would you do in your clinical practice? Would you have sonographic follow-up? Would you go for MRI? Or would you go for CT? Or would you just send the patient to surgery? Just think about what you would suggest in this patient. So what we did, we performed an MRI, and this complex lesion turned out to be just a simple and very typical hydrocele pinks encasing here the ovary. So this is a typical example of an indeterminate mass on sonography. And the subgroup female imaging of the ECUR advised that in patients who present with sonographically indeterminate masses, MRI is the imaging modality of choice. And MRI is particularly useful when it comes to hemorrhagic and solid lesions, where it is superior to CT. And the technique suggested is an algorithmic approach where we use T1 and T2 weighted imaging and complement this with T1 and T1 fat set. But we have learned from Isabelle's recent papers that we can even do better with MRI. And Isabelle Thomassin-Naggara showed that the added value of perfusion and diffusion-weighted imaging improves the diagnostic capability of MRI to further characterize lesions. And in complex adnexal lesions, she found that there was improvement over T2 alone by using these techniques in more than 23% of cases. The diagnostic accuracy was excellent, and what's also important, this was independent from reader's experience. But before I go into detail, I will start with the very basics. So whenever we have an adnexal mass, these three questions should be answered. Is it really a mass? Is its origin the ovaries? And what's the dignity? So let us start with normal variants. This is a normal ovary of a young female. We can identify the follicles, and this thick rim structure is just a normal corpus luteum. This is again a normal ovary in a young female, and it's important not to call these follicular cysts. Why? Because per definition, only lesions that exceed a size of more than 3 centimeters, like here in this case, should be called cysts. These are quite commonly found. They may reach sizes of 8 centimeters and more. And what's typical for functional cysts and what helps us to differentiate these lesions from cystic tumors is that they will regress within a 3-month control interval in the vast majority of cases. And in sonography, they may be without echoes, they may have multiple echoes, or even have fine septations. So as these functional cysts are so commonly found, the Society of Radiologists in Ultrasound have recently suggested that if we have a lesion that is less than 5 centimeters in size, then we just shouldn't do anything. If a cystic lesion is larger than 5 centimeters in size, and she is in premenopausal age, then sonographic follow-up in a 3-month period is advised. And if the lesion is larger than 7 centimeters in size, this is where MRI is advised to exclude papillary projection. But be aware that when we have adnexal masses that are larger than 5 centimeters in size, then there is an increased risk of ovarian torsion. So what about these ovaries in postmenopausal age? So these little cystic structures should also be considered as a normal finding. The reason is this will be little remnant follicles or para-ovarian cysts. So this is a normal finding, even in postmenopausal age. Now let us go to the question of the origin. This is crucial because the differential diagnosis is completely different if we deal with a lesion that is of ovarian or of extraovarian origin. And it's quite often that taloved cysts that are lesions of indeterminate origin in sonography. And I want to illustrate this with this case of a patient, 68 years of age. She has an indeterminate complex adnexal mass on sonography, and MRI and CT would do the same job, clearly shows that these lesions are of extraperitoneal origin and that they are originating from the spinal canal. That's just a typical incidental finding. The list of differential diagnosis is quite large, but in clinical practice, it's usually the first 4 diagnoses in each subgroup that are the most common diagnoses. In the vast majority of cases, we are not able to differentiate para-ovarian cysts from ovarian cysts. In clinical practice, it is very useful to differentiate, but sometimes it's challenging, to differentiate hydrosalpinx from real tumors, namely cyst adenomas. And what should we look for? In hydrosalpinx, we look for a tubular structure or a convoluted tubular structure with incomplete thin septations, as you see it here. Whereas in cyst adenomas, we look for a mass that has thin but complete septations. And this is how we can make the difference. But unfortunately, it's not that clear all the time, and this is when we should try to achieve a more systematic approach. And there have been features that assist us to differentiate masses that are of adnexal origin from those that are of adnexal origin. And what we look for is demonstration of the ovaries, usually within the periphery of the lesion, or the ovary separate. We look for the vessels feeding these structures, and we look also for displacement patterns. And particularly for the extraperitoneal lesions, what we will find is a displacement to the medial side if the origin is the lateral pelvic side wall, or to anteriorly if the origin is the posterior extraperitoneal region. This is just a typical example of a mass that is non-adnexal in origin. Why is this? Because we can clearly separate the ovary from this lesion, and then we go for the displacement pattern. And this displacement pattern assists us to decide if a lesion is intra- or extraperitoneal. Here, displacement of the vagina clearly shows that this is extraperitoneal. And whenever we have such a site and such a morphology of a lesion, we should either think of hemangiopericytoma or aggressive angiomyxoma. Sometimes it may be challenging, particularly in intraperitoneal lesions, and this is a case. But look at the history of this lady. She's quite young. There was a history of enlargement of known pelvic cysts, and she had several surgeries for PID. So what we see is a quite large intraperitoneal mass. It's multicystic with thin septations. It's somehow encasing the sigmoid colon. And where's the ovary? Here, the ovary is at the base of this lesion. And on the transaxial, we can see that the ovary is here somehow associated with a septum at the base. And this is not a tumor. That's a typical pitfall. This is an ovarian pseudocyst. This represents fluid accumulation around the ovary. It's typically found in premenopausal age because we need functional ovaries. And what we find is that the ovary is within the cyst wall, like you see it here, as I have shown you at the base of the cyst. And the diagnostic clue is that the form is not round, but irregular and predefined by the anatomical borders. And again, what allows us this diagnosis is the association with age and the history of previous surgeries, adhesions, or PID. So what about ovarian origin? This is where we look for follicles and the peak sign. And the peak sign presents a sharp angulation between the ovary or remnant ovarian tissue and the tumor. These slides show a cystic mass. The ovary on the right side can be identified, but it's just a little bit impressed. Whereas on the left side, we can clearly see the follicles that allow us the differentiation of the ovary and the peak sign in both dimensions. From CT literature, we have learned that particularly in large lesions, tracking down the ovarian vein is a useful finding to decide if a lesion is ovarian in origin. And what we look for the ovarian vein that usually enters an ovarian mass. This is an example, again, of a large adnexal mass. There is engorgement of the ovarian vein, and these veins typically enter the ovary on the lateral side. So this is a left adnexal mass. And what's important is not to misdiagnose these vessels as solid mural structures within such a lesion. Now, if we have decided that a mass is ovarian in origin, we should move on to decide, is it benign or malignant? And ideally, we should be able to differentiate, is a patient of low risk, then she will have surveillance or probably undergo surgery, or if the lesion is of intermediate or high risk, their very close follow-up is warranted and patient will profit from surgery by an oncologic specialist. And the discriminators that are used are clinical information and imaging findings. And this clinical information include age, menopausal status, family history. Very important is the clinical history of cancer, laboratory data, and also we should not forget symptoms. And it's imaging that plays an important role in this risk stratification. And particularly MRI is able to differentiate lesions that are typically benign. And these include major cystic teratoma, endometriomas, hemorrhagic cysts, and simple cysts. And these lesions have to be differentiated from other cysts, and these other cysts may be potentially malignant. And these typically benign lesions usually can be diagnosed by using very basic MRI sequences. This is T1, T2, and T1 fat set. Whereas in the more complex lesions, we need, in addition to these basic sequences, more advanced MRI. We need gadolinium T1 enhanced and diffusion-weighted imaging, or even dynamic T1 gadolinium enhanced imaging. But let us now go to these typically benign lesions. How can we differentiate this? Both teratoma and endometrioma are bright on T1, but if we use T1 fat set, we can see that the cystic teratoma reduce their signal. Endometrioma and hemorrhagic cysts are both cystic lesions. Can we differentiate between these? Most of the time we are able, because endometrioma are multilocular, they are often bilateral, and it's the shading that's a quite typical finding that allows us the diagnosis of endometriomas. But if we are not able, then it's just advised to perform a sonographic follow-up in 3 months, and it is typical for the functional cyst to regress in size, and that's not found in the endometriomas. We should also be aware that endometriomas may present as quite complex adnexal masses on both sonography and CT. And in CT, we might probably misdiagnose this as abscess or even as cancer. And this is not the case in MRI, where we find very specific finding, namely a lesion that is bright on T1, and that shows a shading. This is this loss in signal in the T2 within this lesion. This is a very specific finding. Typical for dermoids is the presence of fat that can be verified by the use of T1 fat set. But we should also consider that CT is also an excellent technique to demonstrate dermoids. The advantage of CT is that we can much better diagnose calcification in teeth that are found in approximately 1/3 of the cases. That's the same case. So, and the vast majority of fat will present as a fatty structure, but unfortunately, 5% of the dermoids may be atypical. And they may mimic several different lesions, including cancer. And this next case just presents a female who presented with a typical and an atypical dermoid. These are the sonographic imaging. The size of these lesions is approximately 3 centimeters. And if we look at T1, this lesion was bright. It showed that classical finding on T1 fat set, whereas the other lesion was completely without any demonstration of fat. Now, let us move to the lesions that are complex ovarian lesions. Here we have an overlap of both benign and malignant lesions, and in imaging we have to use morphologic as well as functional criteria and clinical information. And what's from clinical point of view important is that pain is atypical for cancer. And what we look for are septations, thickness of septations, wall thickening, or solid aspects in a tumor. These are the findings we have used for almost 2 decades. Typical of benign lesions are purely cystic lesions, thin septations, whereas if we have a lesion that is very bright, has very thick septations or mural nodules that enhance, that is a classical finding of suggesting malignancy. However, if we have such complex masses that are cystic and solid, this may not only be a sign of malignant tumors, but this may also be found in tubo-ovarian abscesses. And it's the type of enhancement we should carefully analyze to differentiate between these 2 entities. And this typical for inflammatory enhancement is that this is commonly found bilaterally. We look for tubal structures within these enhancing lesions. Usually there is enhancement in the periphery, and there is haziness of the pelvic fat. Regarding the tumoral enhancement, we should differentiate between malignant and benign ovarian tumors. Typical for the malignant tumors is a well enhancement. But we had, over the last years, problems to differentiate between benign and malignant tumors, and in the literature, this has also been represented. There were case reports showing that there is a small number of benign lesions that mimic malignancy. These include cyst adenomas, stromal-ovary, Brenner tumors, and also tuberculosis. And out of these, particularly cyst adenoma has been described as a mimicker of malignancy. And cyst adenofibroma is a benign tumor that may present as a cystic lesion, but in 50% it presents as a solid and cystic lesion. And what's quite typical is the so-called black sponge pattern, which is seen in this case, where we see a complex mass with cystic aspects, but also very thick septations and probably some vegetations. But look here at the contrast enhancement that is really very minimal. This is very different to the contrast enhancement we would expect in a cancer. This is a clear cancer presenting as a complex mass with cystic and solid structures. What we see is also high signal on the high p-value diffusion-weighted imaging and clear uptake of contrast enhancement of the solid areas. And if we would perform a dynamic contrast imaging, we could see a type 3 curve with avid enhancement, even more enhancement as compared to the myometrium. And it seems that, again, Isabelle Thomassin-Naggara's paper will help us to overcome the difference, the difficulty to differentiate between malignant and benign tumors that may mimic cancer. And what she has done, she has suggested a scoring system for Adnexal masses. Number 5 is a typical cancer, as I've shown you. Score 1 would be no mass. Score 2 would be the classical benign masses we are able to diagnose, like endometriomas, cysts, or fatty masses. And to differentiate between score 3 and 4, we use the dynamic contrast pattern. And the lesion that is probably benign, as score 3, shows type 1 contrast enhancement. And this I want to illustrate with one of Isabelle's cases. On the left side, a complex adnexal masses can be seen. It has thick septation. There are some solid elements. And after contrast enhancement, on the dynamic contrast enhancement, we will see that the pattern is a type 1 enhancement with very little enhancement. So this is suggestive of a benign lesion. These data have to be validated, and a large multi-center study is now going on. In the next years, you will hear the results of these studies. But you can use this also in your daily practice, particularly if you deal with masses that are not so characteristic for your characterization. And I want to share this case with you. This is a lady, she's 56 years. She presented with bilateral adnexal masses. She came because of abdominal pain. And the coronals show a left adnexal mass and a quite large right adnexal mass. And look here again at this black sponge pattern. But what about this large right mass? On the transaxial, we can see that there are a lot of fluid levels. This is T1, and after contrast enhancement, there is little enhancement only within these septal structures, whereas the large lesion here doesn't show any contrast enhancement at all. So the patient had surgery. This was bilateral cyst adenofibroma, as suggested, but the lesion on the right side had necrosis due to torsion, and this is why there was not any contrast enhancement at all. Diffusion didn't help so much in this case. And the diagnostic clue was, again, this was a patient admitted to pain, and pain is atypical for a patient presenting with ovarian cancer for the first time. And the lack of contrast enhancement here allowed the diagnosis of torsion. So I come to the end. Imaging allows confident diagnosis of the vast majority of cystic masses of ovarian and extraovarian origin. Challenging lesions include atypical dermoids, rare benign tumors, including cyst adenofibromas and adnexal torsion. And in intermediate cases, complementary diffusion-weighted imaging and dynamic gadolinium T1 imaging will allow for risk stratification. Thank you very much.